Hey, ladies and gentlemen, boys and girls, Mel Herbert here. I think it's working this time. Last week, Zoom wouldn't talk to YouTube, but now I believe we're actually talking to you live. It's fantastic to be with you again. So we have a lot to get through this week. We've got a lot of special guests. We've got some really interesting stuff going on. So I'm going to try and share with you a couple of slides here just to sort of orient us for the evening. Swatty, can you see those puppies?
Indeed we can, Mel.
Excellent. So quickly, we're going to do a little intro here, then we're going to get some reports from the front line. We're going to talk about some convalescent plasma that one of our colleagues gave. We're going to have a very special guest talking about clots and the prothrombotic state in these patients. We're going to talk about some critical care updates, lots of therapeutic stuff. Just we'll get through them very quickly, some new studies that have come out. Some risk stratification stuff, but mostly about how careful you have to be about reading and implementing some of these papers that are not peer reviewed. We're also going to talk about, from a science point of view, how we get back to some sort of an economy. COVID is not HAPE. We've got a nice little thing on that, some cardiology updates. And if we're lucky, we're going to get to talk to our colleague in Chile, Pablo Aguilera. So just for those of you that don't know, on EMRAP, we've got this free COVID resources center. There's a whole bunch of stuff in there. The textbook chapter is in there. There's stuff for low resource settings. So if you haven't seen it, it's all free, open access. As you know, we've got the chapter, we're updating it about every day. Jess is working really hard on it. She couldn't be with us in person tonight because she's a real doctor. And in addition to doing the chapter, she's actually seeing COVID patients right now. The Spanish version is up, which is very exciting. This is my favorite image of the week. I just think it is fantastic. I can't actually read who the artist is, but it's genius. I also wanted to shout out to Salem Razai, who's got Rebel EM. He's been firing me papers and I've been firing him back in the papers back and forth, trying to keep up with the explosion of information here. And it's really hard to do. And somehow he's able to do it much better than me. So thank you, sir. You're a good man. EMRAP Go is a non-profit, and we're sort of changing from sending people all over the world and bringing people from all over the world, because you can't do that anymore, to really focusing on this. So we're going to have a Japanese edition of the chapter. We're going to have Portuguese. We're going to have Farsi. We're going to have Hindi. We hope to do a whole bunch of translations within the next few weeks for our colleagues that haven't gotten hit yet. So important stuff. This is a podcast that's been going for years. It's called This Week in Virology. It's a group of the most geeky virologists you've ever heard. And they get together and they just talk virology. And obviously they've been talking a lot about COVID, and I find it spectacularly useful. For example, this week they had a virology friend who's doing 2 of the 3 big chloroquine studies here in the US. And despite what is written on the CDC website, that says we're not going to get results from this for a year. He's like, no, I'm the principal investigator. You're going to get results by the end of the month or early next month. We're going to pre-release this information as soon as we know. The enrollment's going very fast. They have over 500 patients that they're going to enroll. So go listen to this podcast. It's pretty cool. This slide is interesting because it's actually from LA County. It's for some colleagues down the road. And it says that if we just immediately go back to normal life, 96% of Angelenos will be infected by August 1st. And obviously that means a significant percent of those will end up in the ICU and we will be crushed. Beyond all recognition, the healthcare system will be absolutely crushed. We can't do that. If we continue to do this sort of social distancing or physical distancing we're doing now, the models right now suggest that about 30% of people are going to be infected by August 1st. We can do that. That's a crushed enough curve for us to be able to stay ahead of it. If we do more of this physical distancing, be more aggressive about it, we could get it down. But some of these serology things we're going to talk about with Dave Schriger, because it means even by August 1st, the vast majority of us will not have been infected, and that's a problem for getting back to real life. And I throw this in here. This is the biggest to date ambulatory chest x-ray study by a colleague of ours, a friend of the show, Mike Weinstock, a personal friend to many of us, really a Herculean effort. And guess what? You can have COVID and have a normal chest x-ray. You can have COVID with an abnormal chest x-ray. So I'm sorry. Last week, Swami talked to us about Dr. Pruden, and we have a video that we'd like to share with you now. So Graham, share away.
Mel, you got to unmute yourself.
Thank you, Stuart. I hope you're inspired by that video. I certainly was, shedded a tear or two. You're all those heroes. You're just like him. You're out there doing this thing, and we're so happy that he's back off the ventilator and in rehab and doing really well. So Swami, you are still, unfortunately, the epicenter of this thing. So tell us what's happening.
Yeah, thanks for the video, Mel, Josh, the rest of the production team. Our team is really deep in it, and we kind of need a pick-me-up. So I think that's going to really help lift a lot of spirits. Jim getting released was obviously a big lift for us. So we expectedly hit the plateau last week, as we expected, and things seem to be trending down, sort of. It's an interesting experience because the volume of patients coming into the department is much lower than what we were seeing 2 weeks ago. But the level of illness of the patients that are coming in now is very high. So we're not seeing a tapering off necessarily in how busy we are. And of course, we still have lots and lots of patients boarding in the emergency room, waiting for critical care beds, waiting for floor beds. And so the department itself is full. And even though we're not getting a lot of people coming in from outside, it's hard to find a place to see everybody. So we've converted pretty much any space that we possibly can in the hospital into sort of surge areas, cots, anything we can do to get patients seen. And it's definitely helping to get through the volume. We're again seeing a market drop in our numbers, and talking to my colleagues in the city, they're seeing very similar things. All of their EDs are busting at the seams. They're all full of patients who are admitted waiting for beds, but they're not seeing as many patients coming in. So I think we are on that plateau. The things that I'm worried about, Mel, is one, if people break down those physical distancing barriers, we're going to see another surge. It's going to come. And the other thing that worries me is that any little surge now is going to completely tip the hospital over because the ED is already full. Whereas 3 weeks ago, we were relatively empty. Now we're already full. So we're not really going to be able to meet that surge. Those are the things that worry me. And again, talking to friends in the city, saying virtually the same thing. Their emergency departments are completely full. So we are seeing still lots and lots of sick patients. We're seeing still a lot of the comfortable hypoxic patients. When you talk to them, they tell you, oh, I just started having symptoms for the last 2 or 3 days. So there's still that early phase. The good thing is that we have learned a little bit from our prior mistakes. And instead of taking those comfortable hypoxic patients and intubating them early, we're now pushing and pushing and pushing back those intubations. And more of those patients are never getting intubated. So I think we've learned a little bit from our experiences 2 weeks ago, learning that these patients don't get extubated very often. And that's definitely helping. I had 2 patients yesterday that came in with SATs in the 40s, but they were both talking. They were not tachycardic, and they were able to almost speak in full sentences. They didn't come up with either nasal cannula or non-rebreather. We have no CPAP machines or high flow nasal cannulas left in our department. And so we've been MacGyvering CPAP devices thanks to Rich Levitan and George Kovac and Scott Weingard, who have helped us to put those together. And we have been able to really bridge people and keep them off of the intubations and pretty healthy. We're doing a lot of proning. And we're not really doing proning on the intubated patients. That's a little bit difficult. Not the physical turning the patients over. That's quite easy. It's the managing the patient when they're flipped over, which is not easy. And neither us as docs or our nurses are really prepared for that. But we're doing a lot of proning with the awake patients. And there's a couple of protocols that have been out there. I think Scott, again, put out a protocol where he basically has the patient lie left lateral decubitus position and stay there for a couple of hours, and then turn over to the right side, and then flip over on their stomach if they're comfortable, and then sit up if they're comfortable. And I'm mainly doing that, or we're mainly doing that in our apartment with people who are on the high flow nasal cannula, if we have them, on CPAP or the MacGyver CPAP that we've been putting together, or just on non-rebreathers and having them reposition. What we're finding is we just tell the patient, wherever you're comfortable, just lie that way. And they kind of do it themselves. You don't really have to do much. We round on them every hour or two just to see how people are doing. And they just kind of find their way into comfortable positions. So we're doing a lot of the proning. We just got a couple of these are crazy massage mattresses. They're massage mattresses for pregnant people. And we got those from Rich Levitan and his brother, who shipped those out to us for free. And we're going to start trying to prone some more of our patients using those. And the problem that we have with proning is that our patients who are a little bit more on the heavier side, we weren't really able to get them prone on the hospital gurneys. So now we're going to be using these massage mattresses and trying to do that. So lots of awake proning. I really stress to everybody out there, if you haven't seen the surge already, vents are great. CPAP and high flow nasal cannula are much better. So if you can get more of those devices in your apartment, that's great. If not, learn how to build a CPAP on your own. It's really not very difficult. All you need is a bag valve mask, a PEEP valve, a viral filter, and a couple of oxygen supplies, and you can make this work. And we've got some good images on our site, and Scott's got some great images as well. So go check those out. And the last thing, Mel, is med shortages. This is also something people can prepare for. You're going to run out of whatever you want. Just name a drug that you like, and you will be short on it, especially fentanyl and propofol, any of your sedatives. I think at one point we're running very low on rocuronium, but we've got it back now, which is great. So it's a good time to start preparing for those shortages. Talk to your pharmacy, come up with workarounds. We're using a lot more hydromorphone drips, which is not something that we used to do in our shop, but now we're doing those because we're out of things like fentanyl and morphine. So prepare for that. And again, we have a good reference in Corpendium of all of the different substitutes that you can use for this. And I think that's pretty much the update, Mel. Lots of sick patients, less than we were having before, but the EDs are nice and full, and hopefully we can start to unload those in the next couple of days.
Thanks for that update. Look, I talk to people all over the world, and they really just love getting this, like, what does this really look like before the wave gets to us? Here in California, it's also super regional. Some hospitals are dead. Some hospitals are really overcrowded. Jess is going to give us a little feel for what's happening in Central California as well. So let's roll that video.
I think every part of the country and parts of even within the same state are experiencing the COVID-19 outbreak differently. In Central California, I'm in Fresno. I think are still in the calm before the storm, but we felt that way last week and the week before. And I kind of wonder, is the storm coming? Because it's hit the Bay Area, it's hit Southern California. We've had cases, but it hasn't hit us in any way, shape, or form like these very urban areas are getting hit, like New York. So the ER is incredibly slow. We put out this message, this plea to patients to please stay home, and they have. They really have. Like, where are all the patients? Where are the heart attacks and the strokes and the gallbladder attacks and the pancreatitis? Like, where are they? They're not showing up, at least not in significant numbers. So we're getting prepared. And I'd say our department leadership is doing an awesome job communicating with us and with other departments in the hospital. We're getting ready to shift beds around, move patients to convention centers or hotels, and clear out the ICUs and the hospital beds so we can get these patients where they need to be, where they can get the treatment that they need. But honestly, we're still waiting for them to really show up. We're still doing the screening out front in the tents, and that's working well. We're doing the telehealth system there. So we're using GoToMeeting, and we have a few cameras set up, and we talk to our patients on laptops. So we typically don't need to go out there. If we feel like they're sick enough that they need an in-person evaluation, not just screening for swab or no swab, we bring them into a warm zone, and we've converted one of our pod areas right now to the warm zone. So that's blocked off with curtains, and that's full PPE to go into that area. And what we're expecting is going to happen is, as we see more and more cases, that warm zone is going to get larger and larger. And if we ever get this huge influx of patients, the whole department will be the warm or the hot zone. We're nowhere near that right now. And hopefully it doesn't get to that point. So as of now, things are still pretty well managed here in Fresno.
All righty. So thanks for that, Jess. So, a few weeks ago, pretty early on in this whole business, I was watching CNN, and I saw a pretty incredible gentleman who was recovering from a hospitalized patient recovering from COVID. And there was a whole feature of him trying to give his entire circulating volume for science. He was like, I want to give it all. He was like, take as much from me as you can, because I beat this thing, convalescent plasma. And so I was always curious after that, where exactly did those units of plasma go? And we have an answer for you tonight. We're really, really pleased to be joined by Mike Katz. Mike is a graduate of the UCLA program, so he was part of the whole Mel Schriger Talan Club tonight. And he's an intensivist, emergency physician, internal medicine specialist, neurocritical care specialist. He's done it all. And now he's working as an attending physician in the ICU at St. Jude in Orange County. You know, he used this convalescent plasma. Mike, why don't you start off by telling us, welcome, what is the general background and how does it apply to COVID, convalescent plasma?
Sure. Yeah, thanks for having me. Yeah, this was a really interesting experience. I certainly learned quite a bit, and I definitely want to say that this wasn't something that would have been possible just on my own. I had good support from a hematologist at our hospital, as well as one of the pathologists who's one of the doctors that helps run the lab here, and also administrative support because there ended up being some complexity with actually getting the unit even to our hospital. But basically, a little background. So, convalescent plasma, using that to treat acute disease is not a new idea. It's been going on for a long time, studied in a lot of different diseases, especially viral diseases. For example, we currently have immune globulin treatments that we use for Hep A, Hep B, tetanus, diphtheria, and those are more purified products, so like a hyperimmune globulin. There was a report of some outcomes from the 2003 SARS epidemic. The paper is Chang et al. And that was reported in 2005 with outcomes from 2003 in China. And they looked at about 1,700 patients, and they reported that 80 of those patients received convalescent plasma at that time, and they reported a statistical decrease in mortality rate from 17%, which was overall for that whole population, down to 12.5%. And then more recently, just a couple weeks ago, on March 27th, there was a paper by Shen et al. Published in JAMA that was just a series of 5 critically ill patients in China. And basically, they just described the outcomes for these patients in some detail. But basically, over the course of 2 to 3 weeks after getting basically the equivalent of 2 units of plasma that we'd usually give here, patients, 2 of them had been well enough to be discharged. 3 of them were still in the hospital, but had been extubated. And as we see, with patients having such long runs on the ventilator and everything, I mean, that sounds like pretty good news from where we're at right now. But of course, this is it's very limited what conclusions we can draw from that, right? Only 5 patients. But, definitely left the door open to do more of that. So FDA currently considers convalescent plasma to be investigational, but they do have an emergency process that can be accessed to be able to make it available for a patient.
All right, so that's a great background. And so I want to get kind of into the nuts and bolts a little bit. Let's just, what are the actual steps? I mean, first you have to identify a donor, right? And then you have to get FDA authorization. Just walk us through exactly the nuts and bolts of what exactly you got to do.
Sure. So, you can obtain convalescent plasma from whole blood. I think everybody understands, and that's done with a pheresis machine. And there's different kinds of pheresis machines. Some of them can separate a sample like this. Some of them can't. There's also a process that can be done in the lab. So, it's possible in a dialysis unit, in the area that you work, at the center that you work at. They might have the technical capability to do this, but of course, there's a lot more complexity than that. After the sample is obtained, well, first of all, it's ideal if it's done through a regular blood procurement agency that's used to doing, all of the quality testing and everything like that on the unit, and all of that can take some time. So we say, that this can be authorized, available as an emergency, but it's a bit more of a process than that. And really, if it's something that, that you want to use, you have to think ahead a little bit, get the wheels in motion would be ideal. But in terms of identifying a donor, there are criteria on the FDA website. You want to have a patient that was proven positive by PCR or by antibody titer. Ideally, you want them to be 28 days post complete resolution of their symptoms. Or they also say you can do 14 days post resolution of symptoms if you have negative antigen testing. Also, male or female donors, but if it's a female donor, they should have been tested since their last pregnancy or never pregnant as a screen for HLA antibodies. And then they also would like, this part's not required, but suggested SARS-CoV-2 neutralizing antibody titers if available. I wasn't able to get that test sent. I don't think it's widely available yet, even as a send out that I was able to find. But they say if you can't find it, consider freezing a sample so it can be tested later. And we did do that, hoping still to get those results at some point, just to have better understanding of how things went. It's important, as I mentioned before, too, just, obviously the FDA wants you to do the typical infections that can be transmitted by blood transfusion. You need to do the regular screening on these units that would be done on any other kind of blood product to make sure that it's safe. And that can take some time, so something to think ahead for. But basically, when these criteria are satisfied, ideally you want to find a regular blood procurement center and have them procure the sample for you and give a directed donation then.
Okay, I mean, that's really, really helpful. Now your personal experience, I know that you're never going to forget. I mean, what the story that you told me yesterday, the twists, the turns, and how this turned out, everyone needs to know this. Everyone needs to hear this. Tell us about what happened. One of these units made its way to your hospital. Tell us what happened.
Yeah, so basically, hey, to the credit of, one of the hematologists at our hospital, hematologist at another hospital in our system, administrative support, basically we have a morning huddle where we go over all the PUIs, all the known positives. We've got patients cohorted and we kind of review the list and make a plan for the day and get updates, about PPE supplies and the whole thing. And so they pulled me aside after the meeting and they were like, hey, Dr. Katz, you have a few minutes. It turns out that this, 1 unit of convalescent plasma is available at another center, and maybe we should get that for your patient, because your patient is the sickest patient right now. And I'm like, hey, sounds great. And then they're like, oh, we just need to contact the FDA for emergency authorization. Meanwhile, I've got the triage phone. It's blowing up, right? I've got the emergency department calling. I've got, patients coming out of the OR, nursing calls, et cetera, et cetera. So I'm like, okay, well, what exactly is this going to take? I did get some support from a couple of the other docs, which was certainly helpful. But, still, basically what I did, I went onto the FDA website. There's a 2-page form. That wasn't too hard to fill out. You email it in. There's an emergency phone number that you can call if you want this thing to really happen over the course of hours. They prioritize your email. And then after all of that was submitted and done, some basic clinical information on that form, not too bad. After about 45 minutes, I did get a call back from a physician at the FDA. And I don't know exactly where she was. She asked me a couple additional questions and was like, yes, sounds good, Dr. Katz. We're going to, give the authorization. And then it was crickets, so a couple more hours passed. I start getting called by the lab and everything. Okay, what's going on? Are we sending a courier? How do we get that unit? Okay, well, I still don't have the authorization in hand. They said they would, but it was all over the phone, right? So I had to contact the FDA again. Finally, they did at least release the number to me. So you need to get an authorization, that is documented with a number called an EIND number. This is Investigational New Drug Application Number, E, for emergency. And, this is the way that investigational treatments can be authorized, for specific situations. So finally, I did get that number in hand, and then things could start moving. But when we started to try to look into moving the unit from the place, where it was, people were like, whoa, we've got this 1 unit of convalescent plasma, and, not all the testing and stuff is done. And it was complicated. We had to have more meetings, collaboration, call back the FDA, spoke with a couple other doctors at the FDA, and eventually it was explained that, yeah, procedures like this, procuring the unit even outside of a regular blood procurement center in the course of an emergency is allowable. And they gave me some code sections. They're like, why don't you document this in your note? We're not going to have time to type the whole thing up, but you can document these code sections. And they ended up, signing off on the whole thing. Okay, so all of that obviously, took hours still. And then, the other part of this process is it needs to be run through an IRB. And so you need to have some affiliation or contact with an IRB that's active and can make a representative available to kind of sign off on the whole thing and get you consent forms. So there was eventually a 6-page consent form that came to me, and I needed to, of course, go through that with the family and answer all the questions, get that signed in 3 different places by multiple people, send that back to them. After the plasma is administered, there also is a follow-up report because this is an investigational reporting and everything. So somebody has to keep track of all that. So got all that done. Of course, that whole process took a while longer. Needless to say, I started my day that day at probably 5:20 in the morning. 10:30 at night, this 1 unit of prized convalescent plasma arrives in our ICU, and we hang it with anticipation. We're staring at the IV pump, right, as it slowly goes in. Pretty anticlimactic. I mean, this thing ran in like any other unit of plasma that you would see run. And afterwards, of course, we're watching the vitals. And look, this was a guy, 52 years old, no past medical history, who was in severe ARDS, getting difficult to oxygenate, so high vent settings. He was on CRRT, he was on multiple pressors. And so, I mean, we were up against the wall, and we're watching, is anything going to change? I mean, of course you might expect there's no big changes that happen. So the unit ran in, you're watching for allergy, any kind of usual reactions. That didn't happen. The next morning, the patient was still basically in the same clinical state. I had already presented this patient potentially for ECMO. And so that discussion and process continued. And by the next morning, things were lining up for that. There was bed availability. The requirements or the criteria that we're using in our region for that right now are quite stringent, since supplies are back ordered. There's limited circuits, beds, et cetera, et cetera. In any case, the patient was received for ECMO that next morning, cannulated. I'm happy to say now this patient's been extubated. He's awake and communicating. He's on rest vent settings, FiO2 of 21%, and he's cannulated through the neck and subclavian. So they're mobilizing him. So really exciting. How much of that was ECMO compared to convalescent plasma? Maybe a mixture. Maybe he was going to get better anyways. These are the questions, right, that we won't know, for sure. But it certainly felt like the right thing to do.
That's just it. It's amazing, and as I say, you'll never forget that. And there were several other units that went to different places, and I understand that one of the patients didn't survive. I understand, and perhaps it's being used as such a Hail Mary at the end that it didn't have a chance to. I don't know, but let's talk about the future for convalescent plasma. What are the next steps? What's going on nationally?
Sure. I mean, I think it stands to reason. There are many unknowns right now with using this therapy, and so I think anything we can do to try to gain more information, right, about its efficacy. For example, we have no idea what the right dose would be. I mean, in that case series from China, they gave 2 units. I was only able to give 1 because that's all that was available. And so, when would we have more plasma readily available? For us to get this 1 unit was quite difficult. So blood procurement agencies, are they going to be able to develop a universal bank of donor plasma that can be requested, quickly matched, that's already been screened for transmissible diseases and things like this, and quickly matched and provided? If so, how will that be allocated? Which organizations, which patients would get priority? A lot of questions related to that. Probably a lot of people are aware there is a national trial going on right now that we have now become a part of through Mayo. So hopefully we'll get some data and reporting through that to answer some of these questions. Also, the timing of this therapy, right? I mean, is it while viral replication is still ramping up and you can maybe inactivate those viral particles with the antibodies, that this thing is of the most value, or is it still of value at some point later in the phase because there's still some virus floating around continuing to infect? I mean, we just don't know any of those things. For right now, then, I would just say, it's good for people to be aware that you can, when this unit was given just about a week and a half ago, Red Cross was not currently ready to be contacted and procure a unit. Like, let's say in your institution, you're pulling out all the stops for a patient and you find a donor. That's another question. Do you have a database going in your system at your hospital, in your clinic, whatever, that's keeping track of positives? So that you could contact that person later and ask them if they'd be willing to be a donor. And then, right now, if you find a person like that, now you can contact the Red Cross. They ultimately hope to have universal plasma bank available But that looks like it's still at least a couple of weeks out. That even might be optimistic. Maybe it's going to take longer. But right now, you can contact Red Cross, is my understanding, at least in our region, and send a donor to them. They'll procure and test the unit and direct it back to you.
That is so incredibly helpful. Thank you so much. We're going to move along to Swami and introduce our next guest. Thanks so much, Mike.
Thank you.
Yeah, what a great story. So I get to introduce Tom DeLoughery. I think a lot of the EMRAP listeners have probably remember Tom. Tom's a professor of hematology. He's over at the Oregon Health Sciences University. And the reason we asked him to come on is because there's been a lot of talk about clotting, about PEs, DVTs. Tom, I actually saw a patient with an arterial thrombosis and an acute ischemic limb. So there's a lot of clotting going on. And we were hoping that you are going to tell us the key to all of this, how to fix it, and the cheap and easy medication that will make all of our patients better.
Well, great. So that's just a simple thing to do. The one thing that people have been struck by with this viral infection is the very intense pro-inflammatory state. And our thinking is that the hypercoagulability is due to two things. Inflammation leads to hypercoagulability. People's endotheliums get inflamed, you get fibrinogen raised, you get prothrombotic proteins raised. And there may be also an element of the virus itself. It may infect the endothelium, adding to the hypercoagulable state. But certainly what you're reporting is what colleagues of mine are reporting, that, we see DVT rates of 30%, ECMO lines, dialysis lines, continuous filtration lines clot off, arterial ischemia, which is, usually pretty unusual in other infections. And just outrageous fibrinogen levels of like 1800, when the upper range of normal is 350. So probably clearly both a very intense inflammatory state, and maybe, and this is more theoretical, a viral infection of the endothelium adding to this really hypercoagulable milieu.
Tom, so the D-dimer is part of my standard COVID panel when we order for a patient we think has it, which in my department is pretty much everybody right now. And these numbers are coming back sky high. I tried to age adjust the other day, and I'm like, unless the patient's 1,000 years old, this D-dimer is too high. But we're getting numbers that are 20. And I mean, that's basically 20,000, right? On the scale that we're looking at. What do these numbers even, do they mean anything at all, or is it just the fact that there's a lot of inflammation going on, or does it have any prognostic indication?
Well, one thing that's really been striking about literature is a prognostic indication. I think we've gone jaded with the D-dimer. We tend to poo-poo it. What's really remarkable in several studies, it's a very wide dichotomy. People have normal D-dimers, maybe mortality 3 to 5%, high D-dimers 20, 30, 40. And that's really different than seen in many other studies and other prognostic things. And I think it's both the marker of inflammation that's really key, that somehow people with high, these ginormous D-dimers, they're reflecting the underlying sickness of the patient. And classically we teach that D-dimers are breakdown products of the fibrin clot. There's actually some evidence, especially from the original SARS infection years ago, that there's a lot of coagulation in the lung going on, that there's a lot of breakdown of fibrinogen and maybe local fibrinolysis adding to this. So it may be also a marker of the lung damage, but they do seem to be prognostic. And there seems to be, this idea that there may be a threshold, that if your D-dimer is above 3 to 6 times normal, should you anticoagulate the patient empirically? Are they having thrombosis? And that's really some of the big discussions going around now in clotting circles.
That's such an important thing, what you just said there. When we're looking at these D-dimers, this is not D-dimers positive, now we should go get a CT-PE or a CT angiogram. And I think that's really important, because we have to do these terminal cleanings after we run these patients through CT. Although again, in my department, everything is covered with COVID, so we no longer really care about that. But at some point you are thinking about these processes. So it shouldn't be D-dimers elevated, now I have to get a CT-PA. But in that situation, what is your threshold to say this D-dimer is elevated enough that either I'm going to give them a prophylactic dose of some kind of an anticoagulant, or I'm going to give them a therapeutic dose of an anticoagulant? What do you have numbers that you're like, if it's below this, we're good. If it's in this range, I'm going prophylactic. If it's in this range, I'm going therapeutic.
I think the thinking is right now that probably anybody with COVID should get prophylactic anticoagulation. That's some of the movement our hematologic society's made, because even a mild infection may be inflammatory. And then that's been part of the interesting discussion. What do you do at the ginormous levels? And it's interesting, one of the recent studies out of China, the D-dimer was sort of just basically 1.5 or 1500, that had a specificity of 88% for some sort of thrombosis, and a D-dimer of 3000 or 3.0, depending what units you use, was up to 96%. So I think there's a thought that if you have a D-dimer over a threshold, especially if there's some hint of thrombosis, boy, their pulmonary status doesn't look right. Of course, that's the whole infection. I think people are moving more and more towards empiric anticoagulation. So I think clearly if somebody decompensates, clearly if somebody's more hypoxic, obviously if their arm turns blue, but I think a lot of people are getting more comfortable going back to the idea of maybe just empirically treating for pulmonary embolism. You know, when I was a young pup, we used to use VQ scans, and we used to live with, oh, you know, it's, you know, sensitivity, specificity in the 80s, and we were happy to anticoagulate people forever. And ironically, if these studies bear up, that's kind of the same sensitivity, specificity we're seeing with these D-dimer cutoffs. So I think the field is moving towards 3 to 6 times normal. Maybe really consider therapeutic anticoagulation. And if you want to scan, you know, obviously, again, for many places, going to a CTA, especially if somebody's intubated as a dog and pony show, a lot of these patients will have DVTs and other things. So maybe just getting a quick ultrasound, a quick scan, boom, proving the DVT. You know, again, I'm a purist. You know, the idea to me is still just recommending empiric anticoagulation is difficult, but I think we're getting more to that. But simply, you know, if it is just up 3 to 6 times normal, getting scans, and if they're not doing good, really think about going with full bore anticoagulation.
Tom, let's get a little granular on there. And I just want to clarify one thing you said was that anyone who has COVID, you're saying anyone who you're admitting to the hospital because of their COVID-19,
yes,
we should be doing at least prophylactic. I think that's
correct.
a great tip. And then if their D-dimers are a little bit more elevated, some people are saying 1500 is their cutoff. Some people are saying 2000. Some of this you kind of have to look and see what are my inpatient services doing? What does my ICU want to do? And a lot of times I just ask them and say, hey, it's 1500. Do you want me to give you prophylactic or you want me to give them therapeutic because it's in that middle range? What are you going for? What's your go-to drug? If you had your druthers, you could pick anything you want. What would you like to give the patient as that anticoagulant?
Well, if I was ever made the czar of anticoagulation, which is one of my life goals, is that I would, in a perfect world, like to start off low molecular weight heparin. Big issue with inflammation is these inflammatory proteins, fibrinogen, von Willebrand's factor, they're like a sponge for standard heparin. So these are somebody, if you just do a PTT, you give standard heparin to, you may be giving 4,000 units an hour and the PTT is still in the normal range. Low molecular weight doesn't have that. So I like low molecular weight heparin therapeutic dosing as my go-to if I'm going to do therapeutic dosing in an inflammatory patient. If they need procedures, people are worried. You know, ideally, if you're going to use standard heparin, you should use anti-10A heparin levels to monitor it, because that really makes up for this inflammatory milieu to allow you to monitor it. Again, a lot of these patients I've been called or heard about, you know, they're on 4,000 units of heparin, the PTT doesn't move, but you'll see they have a therapeutic or even super therapeutic heparin level. So my druthers is low molecular weight heparin because to me it's cleaner. You know, people need procedures, people are uncomfortable with it. Then I would say fractionated heparin, but ideally with heparin levels.
Well, I'll tell you that you've made every intern in the country and every nurse in the country extremely happy by saying low molecular weight, because that means that they don't have to get a PTT every once in a while. They don't have to adjust these things, which is actually good because we don't really want people going into the rooms if they don't have to. So there's an advantage to using low molecular weight heparin, obviously. What about the patient with renal insufficiency? Because we are both seeing, obviously, patients who have underlying renal insufficiency are getting this, but then we're also getting a lot of patients who don't have that, but they're getting renal insufficiency as part of this process, which we'll have to have a nephrologist on another time, because I talked to our nephrologist yesterday and he said, I don't know what's going on. Everybody's renal function is off the charts. It's probably getting clotting, who knows? But in those patients with renal insufficiency where, you know, I can't reach for the low molecular weight heparin, or maybe I have to adjust it, what's your second option?
So I think two options there. One is there's a lot of data with dose adjusted low molecular weight heparin, 1 mg per kg every day instead of every 12 hours is good. Again, complex situation, people may not be comfortable with heparin hanging out that long. There, I think two other options would be, again, standard heparin, really in this situation, ideally by heparin levels. You know, another go-to is just change classes altogether. Argatroban, the old standby for heparin-induced thrombocytopenia, you know, is not renally clear, can be followed by the PTT, doesn't have these drug interference. That may be sort of an avant-garde, but another choice, especially if you're running into heparin resistance. And that's something our institution will commonly do with heparin resistance, is switch to a direct thrombin inhibitor like argatroban.
What about the oral 10A inhibitors. So things like rivaroxaban and edoxaban, can we use those in this situation, or we're not quite there yet?
I don't think we're quite there yet. I'm big fans of these drugs. I think they'll be in the water supply. But again, not in this situation. They may hang out. We have no idea what the pharmacokinetics or it is. Again, there's a thought that especially if somebody's been in the ICU, maybe they should be going home with prophylaxis, and there that may be the option. But I still like the parental agents when the chips are down.
How about aspirin? Can I just give everyone a little bit of aspirin? I mean, even the patients going home, can I just be like, here, take an aspirin?
Yeah, we have really no data with the aspirin. You know, the thing with the aspirin is it hangs out for 5 days. So if somebody starts bleeding, starts having pulmonary hemorrhage, you're kind of hosed that way. No good data for it yet. So again, sometimes there's a patient I was consult on that clotted on everything, and I said, oh, throw in aspirin. But I like to save it as my last resort.
If I start someone on low molecular weight heparin and then they get a breakthrough clot, which, I mean, it's hard to even know if it's a breakthrough clot or that was the original clot that they had, but let's just say they get a breakthrough clot, what would you switch to in that circumstance, or would you just increase your dose?
So there's 2 options. A lot of the feeling now is that sometimes just giving more low weight heparin, so increasing the dose by 25%. So instead of a mg per kg every 12 hours, 1.25 mg per kg every 12 hours. They break through that, or that's just something you're not comfortable with. Again, we'll switch to an alternative such as argatroban, thinking as a direct thrombin inhibitor, maybe that's a cleaner mechanism of action for it to work.
Tom, let's talk about the big gun, the one that we've seen a couple of case reports here and there, thrombolytics. Are there any patients that we should be giving thrombolytics? We should be considering thrombolytics. The case series that came out didn't look too positive.
Yes.
But I'll tell you that I've seen a couple of patients where they're cooking along okay, and then they start to decompensate, and it's in the back of your head. Did this patient just drop that big PE, or are they just having lots of microthrombi? And, you know, if they have pulmonary emboli, which, you know, with these dimers of 20, I imagine that they probably have something. It does qualify then as a massive pulmonary embolism. So should I give them thrombolytics without the scan?
Yeah, that still would make me very, very nervous. Again, the case series was intriguing, although it kind of like they didn't do that great afterwards, except maybe some minor changes. That part I'm still pretty hesitant on. I know somebody, you know, has ischemic limb, or you're pretty sure you do, you know, a echo, and like, wow, that really looks like a PE there, or you can see the PE waving in the cardiac chamber, probably there, but I'm still kind of hesitant. To me, that's still in a very sick patient, maybe a bridge too far and creating another thing of trouble.
Yeah, one thing that we talked about, we've had a couple of these cases of relatively young patients who decompensated pretty rapidly. And we've had a couple of cases where we've given the lytics intra-arrest and we've had no good outcomes. But we've talked about the idea of maybe we should be giving the lytic peri-arrest instead of during. I mean, because, you know, thrombolytics, even if you know the person has a PE under regular circumstances, they've arrested, not a very good outcome, but not something we are necessarily recommending, obviously. I have one last question for you, Tom, and then if anybody else has any questions. A lot of these patients are developing DIC, either when they're in the emergency department on presentation, they have DIC, or they're getting it in the unit. You know, DIC is not something that we see very often in the emergency room. It's really something that develops after they go to the ICU. We're not really used to handling too much of it. It does seem to be the clotty form of the DIC, not the bleedy form. Those are technical terms, Tom. I know that they didn't teach you that in hematology fellowship, but bleedy and clotty, they tend to be the clotty side. Is there anything that we should be doing for these patients who are developing DIC? Do we have any specific treatments for this? Are we behind, or is this just good supportive care, cross your fingers?
Good supportive care, cross your fingers for most cases, especially this is a prothrombotic, or I like that clotty DIC, probably empirically giving factors like we sometimes do isn't warranted. So unless they're bleeding, I'm tempted to leave the INR, the fibrinogen, the platelets alone. You know, maybe platelets under 10 to 20,000, that's a threshold, but not any higher. I may be happy letting the INR PTT ride, because again, our fear is that the phenotype is so thrombotic, we may just, I hate to use this cliche, feed the fire. So again, it's, as I always tell the medical students, the most worthless piece of advice, treat the primary cause. Oh, gee, I never thought of that. But in this case, that's what we would recommend.
In your experience, have you seen any of the bleedy DICs? I haven't seen a single bleed.
No,
it's been very clotty.
That's been the remarkable thing I've heard in multiple case series, and even people with very spectacular coagulopathies getting heparinized. I've only heard of one intracranial bleeding, and that's really different. Like I said, there's something fascinating in the coagulation cascade going on, that they're really, really prothrombotic.
All right, Tom, I'm out of questions.
I'm
sure there'll be more that come up as we learn more about this, but let's see, Mel, you got something for Tom?
Yes.
Yeah, from the chat room. So we've got a couple of docs in the chat room who are sort of synthesizing all
Sure.
this. So let's say Swami's got a patient who's not too sick, home on oxygen. Should these patients, if they've got a high D dimer of some cutoff, be anticoagulated even if they're going home?
I think a lot of us are starting to think about, is there a threshold for even the person you see and send home? Part of the issue is that we probably have a lower threshold for sending people home now. So I would say if somebody did have a high D dimer, again, 3 times normal, they're going home, give them a prophylactic dose of rivaroxaban, apixaban would not be unreasonable, because that's somebody who maybe before all this happened, you would have admitted to observe anyway. And I think, again, this seems to have such a prothrombotic phenotype that would not be unreasonable.
What about aspirin? I got a little COVID, feeling a little COVID-y. Should I start taking aspirin?
Probably not. The role of aspirin in DVT prophylaxis is controversial, a thing we can revisit another decade or two. But I think in this case, the best data is still with the real anticoagulants, rivaroxaban, apixaban, heparin. So I'd still stick with those.
Okay, that's great. Thanks, Tom. Thanks, Swami. I think don't go away. There might be more questions for you.
Okay, great.
For
It's
you
been
later.
a blast.
Yeah. So I want to bring in Sara now as we keep sort of try and keep this thing on time. And we're going to talk about L type and H type. We're going to talk about permissive hypoxia some more and some stepwise approaches to oxygenation. I just want to share, can you see my slide there?
Indeed we can, Mel.
Excellent. So this is the paper that first described, back to it. Okay, what are you doing, Herbert? This is the paper that describes that L and H type. And one of the things that Sara wanted to say specifically is the person who wrote this is not just sort of an average Joe. This was somebody who is a world expert in ARDS who came up with this concept. So Sara, to you, can you sort of quickly remind us what these two phenotypes are? And does that still hold? Because that was from a week ago.
And a week is a long time in COVID years, it turns out. So yeah, I think that everybody's experience and as we progress and we see more of these patients, I think this is still holding. Certainly my experience, it is still holding. So the idea with the H versus L type is that your L type is often how we see these patients present. And the biggest difference with your L type of COVID versus your classic ARDS is these patients have really good lung compliance. And that's just really abnormal in ARDS, because normally with ARDS, the same mechanisms that lead to hypoxia also result in poor compliance. So your type L patients have good compliance. They may have profound hypoxia, but probably not due to the usual mechanisms of hypoxia in ARDS. The hypothesis put out in this paper is that maybe it's a VQ matching problem that has something to do with the loss of hypoxic vasoconstriction or some kind of dysregulation of hypoxic vasoconstriction. In addition, these patients tend not to have a lot of alveolar collapse. Clinically, the implication of that is that trying to improve oxygenation by recruitment maneuvers, by trying to open up more alveoli, probably won't help because they're not collapsed in the first place. So that's type L. The type H looks like the more classic ARDS. These patients have poor compliance, worsening interstitial pulmonary edema, shunt physiology, and they have a lot of alveolar collapse. And so for those patients, just like ARDS patients, often the answer to improve oxygenation is to recruit more lung. So that's sort of where this is arriving. And I think the more data that we get and the more people talk this through with each other and compare notes, I do think that type H versus type L is solidifying. But there's a couple of outstanding questions. I think the most major of which is type H a natural part of the disease process? Or is it something that we are doing wrong? We're just not sure how to manage the type Ls, and we are actually causing further damage and injury. We don't know the answer to that. I think another question is, even if it is a natural part of the disease process, what precipitates that transition? Why does it happen in some patients, not others? Why is it so abrupt? And so there's a bunch of outstanding questions, but overall, I think that the more I learn, certainly, and the more I talk to people, the way that this was put out in this paper was extremely insightful.
Okay, so I was waiting for you to say you'd worked out how to stop them going from L to H.
Oh yeah, I'm all over it. I know for sure. No, I have no idea, none whatsoever.
So I wonder if you would do me a favor and walk us through how you take a patient who is a little bit hypoxic, bit more hypoxic, really hypoxic. like, what are you doing at each step, and what are your triggers to get to the next step?
Yeah, so first, I have to tell all of you, I am sorry to report that this week is not the week where I have a magic intubate now number for you. There is yet no magic number that tells us that this is the O2 stat at which you need to intubate. I think that we still have no idea. That being said, I think the theme that we talked about a bit last week is continuing, that it is all about looking at the patient. It's much more about their work of breathing probably than their O2 sat. And a lot of your goal when you're treating them is to decrease their work of breathing at the same time as you're increasing their O2 sat. In addition, I think another theme that's coming up is how variable this disease process is in different patients. But to answer the question, so I have a patient, they come in, and initially I'll just do what I usually do. I'll stick them on some kind of face mask, non-rebreather, whatever's available at the time. But pretty quickly, I think that I would transition to a high flow nasal cannula. And then see, is that helping the patient? Is that making them more comfortable? I really like the awake proning thing. I think it's well known, certainly in surgical critical care, that the lungs were just not meant to be in bed. The lungs don't like being in bed. They don't like lying down. And so the idea of having the patient moving around, not lying flat on their back, maybe proning, maybe on their side. We've been using, the little donut pillows you get in the OR. We've been stealing those from the OR, and those can sort of help with comfort. So if I'm trying a combination of high flow nasal cannula with awake proning, I am already sort of ready to go to intubate, because I have found that it's been very humbling for me. My ability to predict when is the moment that this patient will need to be intubated and will start really decompensating. I feel like my clinical gestalt is wearing earmuffs or something. I just know that I don't always know. So I'm just ready to intubate. I have everything ready to go. Then if that's not working, if my high flow plus some awake proning, I will transition to CPAP. I know that's controversial, but again, my goal here is to decrease work of breathing. And for a number of patients, it seems like it might. The caveat there is we're not talking about CPAP like 20/15, not those high numbers. We're talking about low pressures, just maybe like an EPAP of 5, something very gentle with high FiO2s. The other thing that I can do is try and keep the patient dry. I don't necessarily diurese them unless I think they're overloaded, but this is just not the moment for me to give a bunch of fluid. Now, there's a lot of debate over this because, as we just talked about, there's a lot of renal failure in these patients. However, the two things I would say about that are, one, volume tolerance does not equal volume responsiveness, meaning even if the patient were to improve their blood pressure and cardiac output and maybe perfuse their kidneys better with some volume, that does not mean that their lungs will necessarily tolerate that volume with the inflammation that's going on. And then the second one is, in critical care, I think one of the hard things for me to accept, but a critical thing is you can't have everything you want at the same time. You can't have your cake and eat it too. You have to accept in critical care with patients who are this sick that something is going to have to be sacrificed to improve something else. And this lungs versus kidneys is sort of an age-old competition in critical care. And to me, I am really trying to watch and preserve the lungs here. And so sometimes if you have to knowingly sacrifice something else, I am willing to say their kidneys may take a hit, but one, I know what to do with that. We know what to do with CRRT. We understand the kidneys. On the other hand, I don't know what's happening with the lungs. So I want to protect the lungs over the kidneys. So that would sort of be my progression, and then be ready to intubate as quickly as I need to, when I need to. And unfortunately, as of yet, we don't have another obvious treatment we can give patients to try and prevent or abort the vicious cycle that seems to be leading to intubation, unfortunately.
So the last question before we move on is, okay, there's a lot of controversy I hear from the critical care people, high PEEP, no high PEEP. What's the current sort of thinking?
So there are sort of two camps on this. One camp is we spent years figuring out this ARDS thing. We know the protocol works in ARDS patients. Let's not get creative now with the disease we don't understand. Let's go with what we believe works. There's another camp with an increasingly loud voice that is saying this disease is just not acting like ARDS. And the biggest thing with that is the high PEEP versus low PEEP. So here's the issue. In the second camp, the best way that I've heard somebody put this is the idea of divorcing the FiO2 from the PEEP, meaning divorcing the idea that you can improve oxygenation by recruiting more lung. So I think that in these patients, the type Ls, that's very reasonable because one, they don't seem to have that much problem with alveolar recruitment. They don't seem to have that much alveolar collapse. And so improving their oxygenation by recruiting more alveoli, if they're not collapsed in the first place, doesn't seem like it would work. The second issue is it's not just that we might not be doing them good that way. It's a question of could we be doing them harm? Why? So here's the issue. What we know about the lungs is that the lungs hate overdistension. They hate volutrauma, meaning the alveoli hate being overextended, overdistended, even if at low pressures. So low pressure, high volume, that damages the lungs. So if you have really compliant lungs that are very sort of stretchy, so to speak, and you give high pressure, even though, or I'm sorry, you give more PEEP than you need to, even though the ultimate pressures are not that high, you could be causing volutrauma. You could be still causing overdistension. So I think a lot of people are heading towards a lower PEEP strategy, cranking up the FiO2 and trying to improve their oxygenation with FiO2 rather than PEEP, which is not the strategy that we use in ARDS.
It's crazy. This thing is so, it's so different, and even the smartest doctors can't work it out yet. I want to put this up again because a number of people in the chat room have asked. This is the paper. It's in, it may actually have passed through the editorial process at this point, but here it is here. I'll just put it up for a second before we go to our next section, and we're going to get Sara back a little later to talk about this idea of HAPE and COVID-19. But let's go to the Therapeutics section, and we're going to bring in a new team here. But we're going to start with Jess Mason talking about remdesivir and that article that famously just got published last week.
Remdesivir is one of the potential medications that we hope might work for COVID-19. It's been around for a few years, and it acts on viral replication by blocking the viral RNA polymerase. So it's been tried in other viruses. There's nothing about this that's specific to COVID-19. It was tried in the Ebola epidemic, and there was one landmark study that looked at remdesivir compared with 3 other treatments for Ebola. And unfortunately, the remdesivir arm had to be stopped early because it was so ineffective. So it didn't work out so well for Ebola. What about SARS? What about MERS? Well, there's no human data to show any effectiveness, but there is data in human tissue cultures, so in vitro studies that show some antiviral activity. So promising, but we just really don't know. So now what about COVID-19? Can it be helpful? Should it be used? And how should it be used? Well, these are questions that have yet to be answered. It has been used in some patients in China. It has also been used in the United States, many other countries. In fact, it was used in the first documented case of COVID-19 in the United States. This patient wasn't very sick, just minimal oxygen requirement, got the remdesivir by compassionate use and improved and did well and was discharged. So that's great, but that's one patient. So what we really need is some good, high quality data about remdesivir. And now we have this study in the New England Journal of Medicine that was just published called Compassionate Use of Remdesivir for Patients with Severe COVID-19. And it does not answer that question. I wish that it did. It does give us some valuable information though. So what does it tell us? Well, there was 53 patients who got remdesivir by compassionate use, and they basically just described the outcomes, what happened to these 53 patients. These patients were fairly sick at baseline, ranging from a bit hypoxic, requiring some supplemental oxygen, and many of them were intubated on mechanical ventilation, and 4 of them were actually on ECMO. So quite a range from you're a little bit sick to critically ill. And what happened to them? They got this 10-day course of remdesivir, and 68% of them showed clinical improvement. So they got better or they had less oxygen requirement. That's good. That's promising. 15% of them, so only 8 patients, actually got worse. Now, when they look at the subset of patients who were intubated, this to me is a bit more promising. 57% of intubated patients that they described actually got better, well enough to be extubated. And again, there's no control here for comparison, but we do know that overall, Patients who require intubation and mechanical ventilation for COVID-19, they do not do well. The numbers are not that good, even though that's a very, very small number of patients. So there's some things about this study that are good and some things that are not so good. The things that are good is that they're describing endpoints that we actually care about. Survival versus death, that's important. Oxygen requirement, also important. So that's helpful. And we finally have something published about remdesivir for COVID-19. So we're going in the right direction. But what's not so good? It's not a randomized controlled trial. It's not randomized, it's not controlled, and it's not a trial. It's just describing what happened to these 53 patients. It's also pharma sponsored by the company that makes remdesivir, which is Gilead, and the manuscript was written and prepared by someone who works for Gilead. So we really just can't draw any conclusions based off of this. We really need a randomized controlled trial to start answering these questions. We don't know if it's safe, if it's effective. We don't know the dose to give. What if the protocol really only needs to be half of the medication that they administered? In this study, they gave 200 milligrams on day 1 and then 100 milligrams on days 2 through 10. That's the same protocol they used in the Ebola study. But let's just say it is effective. What if it's effective at half that dose? Or what if you only need 5 days of treatment instead of 10? Well, that's twice as many patients that we could potentially treat with a medication that's hopefully effective. So these are key questions that have yet to be answered. I am hopeful because the world needs a treatment. We are desperate right now. We have to try whatever we got, whatever seems promising and safe, we got to try it. But we really need something that works, and we really need evidence to support that decision. Right now, it's unclear if remdesivir answers that and is going to be a helpful medication, or is remdesivir a treatment that's looking for a disease?
So thanks, Jess. I'm going to bring in Dave Talan because we want to talk to him about a couple of different things. But first, Dave, do you want to say anything else about remdesivir? Or actually, let me ask you a specific question. You've done 1 trillion studies in your time. Shouldn't we have the results of at least a reasonably well done randomized trial? We've got lots of patients. Usually that's the problem. We can't find the patients to put in the trial. We've got plenty of patients. How hard is it to give half of them remdesivir and half of them none and get a result? Dave, are you on mute? Dave, do you care?
I care, but I didn't hit the unmute button. Yeah, Jess, that makes me very sad. It's a very bleak picture that she presents. We're going to have the answer very soon. As many of you have noticed, we have many COVID positive, infected, sick people in the world. We have them in the United States. We have them in developed countries, which have very experienced researchers to do clinical trials. So I think we're going to get the answer soon. I'm glad that they published this series of 53 patients in the New England Journal of Medicine. I want to know if the drug is well tolerated. I want to know, I want to get an idea of how patients who are very sick do. It's not a definitive answer, like she says, but if you look at the group that they had, about 2/3 of them were intubated. A handful of them were on ECMO. And based on the outcomes that we know from many, many patients who are on mechanical ventilation and on ECMO, you would have predicted that the mortality in this group would be about double of what they described. So I would say that this is, I see some hope in this report. And I think very soon we're going to have randomized controlled trials to answer the question. I wouldn't be surprised if we start to see some more meaningful data in just a few weeks. So I'm optimistic about getting the answers. Now, you had some other questions, right?
I've got some others, but
okay.
Just let me ask this question. Pathophysiologically, does this antiviral look like it's got the right target things to shoot at this virus?
Yeah, I mean, it was specifically developed as an antiviral, as opposed to many of the antibiotics, antiparasitics, anti-scabies, sort of Viagra development model of like, we developed it for one thing, but it turned out to help in another way model. So this is a specific nucleotide analog to interfere with RNA polymerase, which is a key enzyme in viral replication. It's a key enzyme in SARS-CoV-2. Now, will it have clinical effects? That's what we need randomized controlled trials for. But this is a specifically developed antiviral agent, so it's got that going for it. And so, you know, I would have better expectations for a drug like this than, let's say, ivermectin or chloroquine or azithromycin.
Which we're going to get to some of those.
Yes.
So we had last week a number of people specifically ask could you sort of answer the question of these patients that we're sending home? It seems like the critical care people are giving a lot of antibiotics for a co-infection with bacterial disease, or they're treating for that. Should we be sending these people home with a Z-Pak anyway? Not to kill the COVID, but to kill whatever else wants to infect them with the COVID.
Well, I think practically, like, who's going to have the courage to see a pneumonia and not give antibiotics? I mean, we never did that before, a deadly, you know, viral pandemic. So you're telling me you hear, you know, abnormal breath sounds and you clinically make the diagnosis of pneumonia, or you get an x-ray, or maybe you go on to CT and you see pneumonia. And I would just, like, when was the last time that you diagnosed pneumonia and you didn't give an antibiotic? But we've known about that viruses can cause pneumonia independent of bacterial disease for a long time. There's been studies on predictors of finding viruses or finding bacteria or finding both. And I guess, you know, if you fear of giving antibiotics, you could try to selectively treat some of the very low risk patients that had very typical presentations for viral infection, viral pneumonia, and specifically COVID. And we all know those symptoms and laboratory findings. I mean, it would be a young person without comorbidities. It would be someone with a more gradual onset of illness, not an abrupt acute presentation of a respiratory infection. It would be someone with a high white blood cell count and not low lymphocytes because the neutrophils are so high, but because the total white count is low and the lymphocytes are low. And they have a very poor sense of smell. That would help. And then they have a little bit of pneumonia, not a lot of pneumonia, and nothing on that x-ray pattern that suggested a bacterial pneumonia. So this would be lower lobe, patchy, bilateral, not too much, can't be out to the pleura and associated with a pleural effusion. And in a patient like that, if there's something about your mindset where you want to restrict antibiotics all of a sudden to people with pneumonia, go knock yourself out. But I don't think there's great harm in that. It's consistent with our practice. We're certainly all very nervous, and patients are probably reassured if you can give them something to do to try to treat their illness. Which antibiotics? Probably the ones, I knew you were going to ask that. Probably the ones that are now recommended for community-acquired pneumonia. And of course, we've moved away from quinolones. Perhaps those will be the next new promising agents to treat COVID. You know, probably next week we'll be talking about that. But, you know, if you wanted an excuse to slip azithromycin in with a beta-lactam, this is an opportunity.
I think the question really came out of the fact that there are places that just ran out of azithromycin, that ran out of so much stuff because they got overwhelmed. And so they're like, well, can we just send them home without anything? Because we're pretty sure it's viral anyway. So that's sort of a slightly different decision-making process. When you haven't got anything, you can't give it.
And by the way, you have viewers from all over the world. In the United States, our Infectious Disease Society recommends dual therapy, like I described, with a beta-lactam and azithromycin or doxycycline. In Europe, their infectious disease professional societies recommend monotherapy with amoxicillin or doxycycline, neither of which have been associated with any effect on COVID illness. So there you go.
Right. Yeah. I just wanted to do a quick update on what is happening with chloroquine, because we've got 2 papers at least since last week. And in one case, it was a high dose versus low dose trial. And it ended up looking very bad for the high dose people. So if you don't do the high dose, they had lots of cardiac issues. And then there was another one which Salim sent to me yesterday. And it basically, again, not a great study, but it didn't show any effect at all. So the magic wonder drug ain't so wonderful after all, it turns out. So I want to hand over to Swad for a second. And Dave, you can chime in as well if you'd like about interleukin-6 blockers and stuff.
Interleukin-6 blockers and stuff. What the heck is that? That sounds like something Sean Nordt would know about, Mel. I did help him with the figure, though.
You did. Thank you. Yeah. So if we bring up that figure, so we're talking a lot about what's going on. So here is Stuart's great artwork and kind of a little schematic about what's going on. So when that virus gets into the cell, and let's say it's the alveoli, binds to the ACE2 receptor and just starts this massive cascade of events, and you get all these pro-inflammatory chemicals. You get your IL-2 and your TNF alpha, and this interferons. All this stuff happens. Well, one of these is predominant, and that's the IL-6, and this causes blood vessels to get more permeable. You get a lot of leak. You get these cytokines into the bloodstream, and then you get this cytokine storm that everybody's heard of, the cytokine release syndrome. What does that appear like clinically? They get fever, they get hypotensive, and then ultimately multi-system organ failure. So if we move to tocilizumab, which is, if you move to the next one, Mel, please. So there you go. So tocilizumab is an FDA-approved drug. This is a humanized monoclonal antibody that's approved for giant cell arteritis, rheumatoid arthritis, some of the juvenile rheumatoid arthritis, and cytokine release syndrome. Now, we see this in COVID, but it's approved for this as a complication of CAR T therapy. So IL-6, as you see, will sit on that IL-6 receptor, and then it just starts this whole cascade of events with that same transduction. If you have this tocilizumab that goes and sits there, well, the IL-6 can't bind to this, and then you prevent those downstream effects. So there is some data that's coming out. There was actually a very nice meta-analysis that came out just the other day, and this is from Coombs et al. And at the University of Toronto in the MedRx IV site. And what they did is they looked at a bunch of different studies and really honed it down to 6 studies from China. 4 of them were retrospective. None of them were randomized. Some of them were fairly small with numbers of patients in kind of the 30 to 40 range. But what are the positive things? They showed that there was a clinical benefit to giving this and even a mortality benefit from giving this, but there's a lot of problems with the methodology. So what are we going to do from here? It's promising, but if Yvonne, I think we have one more slide, because just like Mike was talking about, how do you get enrolled and for convalescent plasma, here is the clinicaltrials.gov. There's the URL if anybody wants to look into this. Now, this is just getting underway, but they are recruiting. So they are looking at adults. They're giving a standardized dose of tocilizumab, which is 8 milligrams per kilo up to 800 milligrams and can be redosed within 12 hours once if someone's not responding, compared to placebo. So this is exactly what Dave Talan was talking about and what we need. We need some proper randomized controlled studies, and hopefully this will be one. So far, this is being up and running in France and a couple of other European countries, but in the US, UCSD, University of Chicago, Baylor, Hackensack, New Jersey are all enrolling patients, and this is going to be rolled out. This is a drug company sponsored study, but at this stage, I think those are really, many of the studies are going to have to be just like that remdesivir study. And so that is tocilizumab, and we're very hopeful about it.
Yes, Sean, I want to ask you, when I'm not that familiar with this medicine, but it's indicated to treat rheumatologic disease, right?
That's right.
And under its warnings, very prominently
Yep,
displayed, is an increased risk of every type of infection.
In fact, yep.
So I mean, is this a little bit of a crapshoot, or is it a drug that might be just the wrong drug at the beginning of the infection? If your own innate immune system might give you a chance of surviving, that might be reserved for people where they have cytokine storm. They're at the end. They're where Sara starts to see the usual ARDS, and there's very little we can do for people like that.
I agree with everything you said. So yeah, if you look at one of the contraindications under normal rheumatologic disease, it is do not give in the presence of infection or severe infection. And that's what we're talking about here. But I agree with you entirely, Dave, that this really should be reserved for those patients who have that true cytokine storm, cytokine release syndrome that are very, very sick. Because if it's early on in disease, I don't think this really has a role and may make things worse because of those immune modulating effects. One of the side effects is it causes neutropenia, which is something that's probably not too hot. It looks like it's margin, really just not really bone marrow suppression that's going on, but I think that if someone's late in disease and showing the cytokine storm, that's the ones that I would be using this in.
All right, well, let's keep it moving here. I want to talk about something else. Thanks for that, Sean. So we will wait and see. I think, like Dave was saying, that all of this stuff is going to be out soon, or at least the preliminary reports. I should say that I was listening to that podcast I was telling you about this week in virology, and one of the principal investigators of the two big US chloroquine studies said that he should be able to release data by the end of the month or early next month about their randomized trials. So I found this paper, probably again, Salim found it for me, about risk factors associated with hospitalization and critical illness, and could you sort of run these people through a little sort of algorithm to work out who's safe to say go home and who should come into the hospital. And it came up with the usual things. It's usually old people, it's comorbid disease, but it also threw in troponins and pro-BNPs and some other stuff. But Dave Schriger wanted to just say, hang on, everybody, just calm down for a second. Why did you want to say that, Dave?
A couple of reasons. Again, the devil is in the details. There is nothing wrong. This is a series of 4,000 patients who tested positive out of 7,000 who were tested in the NYU system in New York. And describing those patients is great. We all need more information about large groups of patients so we begin to understand what they look like. However, when they start to do modeling, there's some certain problems here. So to understand the study, there are two groups of patients being tested. There's a group of patients that are being tested in doctors' offices, special clinics set up for testing of the walking well potential COVID patients. And then there are patients who are being tested because they're being admitted to hospital because they're sick. And it turns out that of their 4,000 patients, 2,000 were admitted, 2,000 were sent home. But the 2,000 who were sent home, roughly 1,600 of those were the ones who were tested in these ambulatory clinics. When you put all these patients together, you no longer have a meaningful cohort. You have this combination of patients who are walking well, patients who are clinically already very sick and being admitted, and any averages between those groups have no meaning. What you really need to do is keep those groups stratified and say, what are the people who are walking well look like? What are the people who are being admitted to the hospital look like? Because then the two things they're trying to predict, and they use multiple regression and they use a cart type analysis to say, well, who needs to be admitted and who's likely to do poorly? The problem is that all those things become self-fulfilling prophecies, because you've made the decision to admit, presumably by a whole bunch of things, which you then look at to see who should be admitted. And what do you find? The people who are more frail because they have comorbidities, because they're older, they get admitted. What a surprise, because that's why you admitted them. So there's a tremendous amount of circular logic here, and there's a failure to keep the strata of the patient who are walking well and tested separate from the patient who are being hospitalized and tested. So the descriptive data is great. The title is misleading in that the modeling effort here is really ill-conceived and really tells us nothing about who should be hospitalized or who is at risk to get sicker and need critical care.
Can I ask Dave a question, Mel?
Yes, Dave, you can, because I was on mute.
I was waiting for that moment. So I agree with you, Dave, about the hospitalization. It's so fulfilling. But what I was interested in is if there were predictors, such as laboratory predictors, of people who came in not so ill, but then progressed to critical illness. And they sort of talk about that, but I couldn't understand whether these laboratory tests were drawn while they were well and were potential predictors of who would progress, which would be important to know, because if you were designing drug trials, it would be kind of nice to focus on a group like that, right? those are the ones at risk. And I couldn't tell if the laboratory tests were done before and they were predictive, or they were done when the person was very sick and just were associated with the person being very sick, and then not very useful. And they don't make that clear in the paper. And I kind of feel it's kind of all those things, right? Do you know?
Absolutely. You know, the way that it's presented, you can't tease out the different groups of patients. I think there are, you know, innumerable questions to ask about every type of patient. The patient who has a cough but is walking around, what are their predictors for ultimately needing hospitalization, for ultimately needing oxygen, for ultimately needing critical care? That's one set of questions. There's another question for the patient who looks sicker and is on the fence. What's going to happen to those patients, and can we predict who goes home? These kind of, I mean, under the current conditions, it's completely understandable where you get these rapidly produced papers that may not be fully thought through. But when you start to combine these different groups of patients in unknowable ways, what comes out at the back end is not very meaningful. And, you know, as we were talking about, of the patients who presumably got the full gambit of tests, remember, 1,600 of the 2,000 who weren't admitted were only seen in clinics where they got no laboratory tests other than a swab. So therefore, there's only about 400 patients left who were evaluated at the same time that the hospitalized patients were evaluated. So now you have 400 of those against 2,000. And again, whatever you come up with from that is going to be very different than if you had a different cohort. So without clear cohorts that have clinical meaning, it's very hard to know what to make of any of this. And I would just simply point out that at a time like this, I was just saying this to the residents at Rounds the other day, meetings of our kind, where you get people who have expertise and who have actual experience to talk about things and see anecdotally what is working, not anecdotally in the sense of, oh, I saw one patient and blah, 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 but sort of the patterns that people are seeing, to get smart people talking about that in a qualitative way and having an interaction where they postulate what might be going on. That is where the real knowledge lies. And you can comb through all of these preprint servers, and the likelihood of getting as much information as you will as listening to a bunch of smart people talking about this, I think, is pretty low.
That was a really important point that I wanted to make. This is dangerous stuff, because I read that paper. I'm not very sophisticated, and I'm like, oh, look, these things predict. And then I sent it to Dave. He's like, you're an idiot, Herbert. So Stuart, you wanted to talk about this?
Actually, I think Swami had the comment.
I was just going to say with and it's anecdote, it's not evidence. It's our, what we're seeing with these inflammatory markers. We do see people who look pretty good, but if their D dimers are 4 or 5 or 6, or some of them are 18 or 19, we're a little bit more wary of those patients, and we tend to watch them like hawks. We try to put them in front of a doctor station because they tend to decompensate over the next 12 to 24 hours. And of course, we're keeping these patients not for 12 to 24 hours, but sometimes for 180 hours in the emergency department. We get to watch them have that decompensation. So I found that the dimer is a really good marker, as well as CRPs over like 125, which again, I didn't know that the CRP goes that high. I thought it stopped at some point, but it doesn't. It just keeps going and going. And if those markers are really elevated, I tend to ask those patients to be moved closer to the doctors and nurses station so we can keep a close eye on them.
All right, well, I'm going to move on to the next part here. And you may have seen this. There was a critical care doc in New York who early, when New York was really getting crushed, had this plea to critical care docs all across the world: don't treat this like ARDS. Don't think about this as ARDS, because it just doesn't act like that. And it was gut-wrenching, and then it went viral, and everybody has seen this now. So one of the things he was suggesting, I think, just trying to get his brain around this, was, could this be like HAPE? Is this like high-altitude pulmonary edema? And so Ken Zaffron, who is an expert from Stanford and works in the Himalayas a lot, treats a lot of high-altitude pulmonary edema, wanted to say a few things about whether COVID is like HAPE, and then I'll have Sarah jump in. But first, let's see this video. All right, why don't you introduce yourself and give us your spiel?
All right, my name's Ken Zaffron. I'm an emergency physician. I live in Anchorage, Alaska, but these days, most of my clinical practice is at Stanford, where I go once a month and attend in the emergency department. I'm also the associate medical director of the Himalayan Rescue Association. And so I have some experience in high altitude diseases, and that's why I wanted to talk to you, Mel, about is COVID-19 like high altitude pulmonary edema?
Is it?
No. We're done.
So a little bit of humor there, but we actually did about a 15-minute interview. It's getting edited. It'll be up on the website tomorrow. But his basic summary was, it's really not like HAPE. HAPE, you've got global hypoxia, you've got vasoconstriction, and then it starts to get leaky, and these people look much more like ARDS. Yes, sometimes they get microthrombi, and so does COVID, but a lot of diseases in the lung get microthrombi. So he really didn't think that that analogy worked. So Sarah, can you give us your opinion?
Yeah, so I think that the bottom line is that initially what the people that were putting forward this idea were trying to do is probably just further differentiate this disease from ARDS. And I certainly agree that especially the type L patients probably look more like HAPE than they do look like ARDS. But that being said, I think until we have better data or any data about the disease actual mechanism, I just think it's dangerous to try and squish this disease too hard into the box of any other disease process we know, whether it's ARDS or HAPE. And so I definitely hear what they're saying. And I think that the goal was to say, let's not treat this like ARDS. And I think that it's tricky because the question of chicken egg really matters in medicine, because even if something looks like something else doesn't mean it is like something else. And I think that particularly with this analogy, to me, the biggest place that it breaks down is that what we know about HAPE is that it's probably too much hypoxic vasoconstriction, bit of an oversimplification, but that's the idea. You get too much hypoxic vasoconstriction, whereas the hypotheses, for example, in the Gattinoni article that are put out about COVID are more along the lines of maybe it's not enough of hypoxic vasoconstriction, or maybe you just have sort of vasoplegia of the pulmonary circulation. And so you can see a similar effect from both of those things. They can both eventually result in hypoxia, but the mechanism really matters when you're trying to figure out what to treat it with and trying to extrapolate what to treat it with.
I'd really like to play Monty Python music now that you've finished speaking, but I don't have any. Actually, I want to go back to Dave Schriger because I forgot to ask him the second part of our section because, I'm not good at what I do. And it's actually a really important one. We're hearing in the news a lot right now, going back to work, and lots of political controversy about that. But I wanted to give you a chance to tell us, how do you do that? What's required to do that from sort of a medical point of view? Because we do have to go back at some point, but most of us are not going to have antibodies after the first wave of this is over.
Right, so the first question, Mel, is whether what you just said is correct. So that we do not yet know really I haven't seen a convincing report from anywhere of a large scale antibody test done in a randomly selected population in a country that's had, is on the back end of this thing. So, it's quite possible that 2% of the population has been exposed, but it's also, if you believe that, the numbers where say up to 50% of people could be asymptomatic carriers, it's possible that there are certainly in certain age groups, there are large percentages of the population in certain areas that in fact have been exposed and have had an asymptomatic or relatively asymptomatic course. You need to know that because in other words, to figure out, does this population have herd immunity? You need to know how many people are immune. And we just don't know that. We don't know whether people are immune because they got it, or we don't even know if some people are immune because they've had other coronaviruses or other conditions that somehow create an immunologic reaction which offers some protection. So there's a lot we need to know about who's immune. And until we know that, we really can't say anything, because what you're talking about, if 2% of the population is immune, if we let this come back, we're in the exact same place we are in now. There's nothing different about it. 98% versus 100% is identical as far as the virus is concerned. So the first thing we need to establish is how many people are immune. And that's done by broad scale antibody testing. And supposedly we're going to have that soon, though it doesn't seem like soon enough. The second component then is to say, is anything different in any other way? Do we have an effective treatment or even a prophylactic type treatment where you could give it to people early on and stop them from getting very sick? If we had that, that would change the game. We don't have that yet. And then the next thing is, do we have the capacity as a nation to do the kind of high level testing, surveillance, contact tracing, and isolation that has been successful in some other countries? And the answer is currently no. I've seen estimates where we need 300,000 boots on the ground workers to carry that out. JAMA published an editorial last week saying that every medical student and nursing student who's supposed to begin school this fall or this summer should report instead to an assigned public health department where they do a 6-month internship spent tracking down cases and to really get this down. The other thing we don't know about is whether RT, the infectivity of the virus, will change over time. In certain parts of the country, the weather's starting to warm up. Will that have an effect the same way that it does with influenza, or are we going to see the same RT month after month after month, which also has implications? But between social distancing, contact tracing, a change in RT if we're lucky, we would need to get the effective RT down below 1 to start getting rid of this thing. Otherwise, as long as there's a handful of cases around, give it a couple months and we'll be right back where we were. So a lot to do before we can say we can open up society again.
Yeah, thanks for giving us that sort of commentary. There's a lot of stuff that you got to get in place to do that. A lot of other countries are in a better place to do it than we are, but you need a lot of testing. I think if the Nordt they're saying might be as high as 6, you need to have over 80% of the population having herd immunity, or it just keeps going. And
That's
it
correct.
does look like it's that infectious. So we've got, this is going to be a while. So Stuart, I want to throw to you now and give us some cardiology updates.
All right, so we have Amal as well, and we're just going to cover a couple of cardiology updates. The COVID cardiology corner, that's with the K, by the way. So the first thing is that I want to talk about this whole STEMI versus myocarditis situation. Both Amal and I have a case to quickly tell you about that really, I think, illustrates the conundrum that people are in these days. One of my colleagues sent a case of a 40-year-old who came in, no real risk factors, 40-something, with some COVID-y symptoms, but prominent chest pain, like Levine sign, okay? And the EKG showed a pretty showed an inferior, looks like posterior extension. Because of all the COVID going around, the decision was made to take the patient, to give the patient lytics in lieu of cath. When he had persistent pain and persistent changes on the EKG, he had cath, and the interpretation was non-obstructive coronary disease. And, the question still remains, is this myocarditis? The troponin went way up. Was this a thrombus that maybe lysed? Was it a thrombus that just on account of the inflammation that we're seeing with COVID? That is, why a person without risk factors would have that? Just still unknown and a total conundrum. And Amal, you had a similar case too, and we actually have the EKG for the case of yours. You want to show that, Mel? And go ahead, Amal.
Yeah, it's really difficult to tell whether these cases are true STEMI versus myocarditis, because the EKG can really look so classically similar. I've been going through probably 1,000 EKGs over the past several days, and I've actually found that there is a definitive way of telling the difference between STEMI versus myocarditis. So
I know. Wait. Are you going to say autopsy?
Well, you could wait that long, but the other way to do it on the EKG is when you look at.
I lost Amal. Did anybody else lose?
Yeah, we lost your audio. Amal, just repeat it. Just repeat the last thing. Repeat the last thing one more time.
It's gone. I don't remember what I just said.
Okay, here, I'll help you. The way that you can definitively tell the difference is go.
No, you can't. You can't. Unfortunately, you just can't. The only way to tell is either in the cath lab or the echo can be helpful, or unfortunately on autopsy. And because of that, when you see ST segment elevation, if you don't have a really, really good story for a STEMI, then echo or bedside ultrasound might end up being the answer. And that's what a lot of the cardiology groups are recommending. But you don't want to just automatically assume it's myocarditis and start throwing lytics at these patients, because then you have all of the side effects of lytics with no potential benefit. And if it is pericarditis, you could potentially even induce a hemorrhagic effusion. So lytics are not the answer. It really still is. If you have a concerning EKG, take him to the cath lab.
And probably an expanded role for echo. The crazy thing about the case that I was talking about was that there was the discussion involved, hey, maybe this is a localized or regional myocarditis. And I'm like, oh, this is too much for me. I mean, you know, I think that there's STEMIs going on still. And that kind of brings us to the next thing that we need to share with everyone, because we brought this up over the past couple of weeks, this whole issue, and Jess has alluded to it, that, you know, what's happening to all these code STEMI patients, what's happening to all these code stroke patients, what's happening to all these DKA patients, and the other issue of what should we do differently. We've had surgeons giving antibiotics to appendicitis. We've definitely seen that. We've definitely seen patients getting lytics in lieu of going to the cath lab. And so you've been, Amal, on this committee that you're trying to write, you know, these guidelines. We thought we were going to be ready like for last week, and there still is a consensus. What is going on?
Yeah, well, the first question about where these STEMIs have gone is really interesting, and it's been talked about by cardiologists really all around the world, that the STEMIs are just not showing up in the emergency department, certainly in the US. And interestingly, I was talking to Evie Marcolini just several days ago. She was saying that in the neurology world, stroke patients are not showing up the way they used to also. And I think the message perhaps has gotten out there so strongly to stay home that many of these patients may simply not be coming in. And I've seen a couple of patients that had cardiomyopathies, bad heart failure, and they had symptoms for several days, and they said, well, we didn't want to bother you by coming in 2 days ago when these symptoms started. And so, you know, it's good and bad, this message that we've seen.
Yeah,
but I think
actually, Dr. Nordt was mentioning to me that in the UK, these patients are simply presenting to the GP's office, and that just must just be terrifying. And just to parse out that, you know, we had actually quite a heated exchange with Mel on this sort of a yin and yang, because, you know, Mel presents the point, you know, what is the risk of getting COVID and getting really sick in comparison to my mortality from my sort of lower end MI or my unstable angina on the one hand, and Amal on the other, saying, let's not let people, you know, let's make sure that we treat people the same way that we always do in terms of, you know, taking them to cath, and let's not shortchange these people. Let's not give consultants an excuse. Let's make sure they, you know, they get what they need. And there is no answer on that, but I wanted to bring that yin and yang out. And I also wanted to give Amal a chance to give your perspective on what you think really the guidelines should end up being for activating the cath lab.
Yeah, well, the guidelines, so there's this consensus statement that you alluded to that's being put out by the ACC and the Society for Cardiovascular Angiography and Intervention, which is the big cath lab organization, and ACEP. And the document is done. It's just being finally reviewed by the organizations. And I can just give you the Cliff Notes version here, in that the interventionalists from ACC and the other cardiology organization have very strongly come out and endorsed that primary PCI is still the standard of care. And those are the words that they use. This is the standard of care. And the only difference that we should be doing with patients that come in with suspected STEMI is we do everything the same, except we just make sure that the PPE is being worn properly for all patients. And so don't say, well, I don't think this patient's COVID positive, so I'm just going to go in with my scrubs. No, you PPE yourself, if that's a verb, for every patient. Mm-hmm. And again, you do pretty much everything the same. You just take precautions for yourself. And again, there's a little bit more of a push only in uncertain cases to use echo. If it's a clear-cut case, right to PCI. And again, that they say lytics can be reserved only if PCI is not available and if you simply don't have the resources. And then the one other thing that I would add, the third key take-home point I would say from this consensus statement is to liberally consult cardiology. A lot of these should be joint decisions. This is not a time for us to be cowboys and say we can do everything on our own. You call them up, you discuss the case, and also skip the ED bypass, where paramedics activate in the field and go right to the cath lab. They really want the paramedics to bring the patient to the emergency department, get some risk stratification. If you have it, do the rapid test and send them right up the cath lab. And the purpose of the rapid test is just to help with figuring out what kind of bed they go to after the cath. But there is some early Chinese literature saying, just give lytics to everybody. And the American societies are strongly against that. They say, do everything the same, just protect yourself with the proper garb.
Yeah, almost like we spent the past 30 years figuring out that PCI was superior.
Right.
So
Right.
please, yeah. And I like your new verb, to PPE yourself. I think that mine is just to pee myself, which is my inclination in these cases. But anyway, so just the last thing we want to cover, I think it's pretty important, is this issue of cardiac arrest. Now, we don't need to, remind everyone about what the data is. It's really, really bad. Okay, it's really, really bad. And what kind of worries me a little bit is what I'm hearing from a lot of the hospitalist and what's happening in the ICU is that, we're going to give these people a code, but it's going to be abbreviated. We're going to do some compressions. We're going to give them a round of drugs, but not go on for the half hour. And we've all heard that. That worries me. If we have the data, Amal, that says that the prognosis is so poor, and we've done everything that we can up to that point, especially in those cases, not the home arrest, the in-hospital arrest, is that really the good advice? Should we not just maybe give the advice to call these codes without aerosolizing COVID?
Yeah, I agree with you. I think the literature on in-hospital cardiac arrest has always been abysmal. Unless it's a shockable rhythm, in-hospital cardiac arrest plus non-shockable rhythm has a horrendous prognosis. And in this setting, I think there's even more reason to not do these so-called heroic resuscitations that go endlessly on and on before you finally call the code. So in-hospital cardiac arrest has a terrible prognosis to start with. And I think it's sensible to call the code to terminate resuscitation efforts a lot earlier, unless it's a shockable rhythm.
Yeah, and I guess it goes without saying that, if at all possible, we have this discussion in advance with the patients and their families, so that we're not in this situation. I know that that's something that Mike Katz was emphasizing, and that's important too.
Absolutely.
All right. Well, thank you so much. So we can't tell the difference between STEMI and myocarditis. We've got new guidelines that say, do things the right way, and cardiac arrest, you can't resuscitate these people. Back to you, Mel.
So I want to bring in Pablo as we finish up here. Pablo Aguilera is an attending physician in Chile. Chile is a little bit behind us in terms of number of cases. So Pablo, I was wondering if you can tell us what's happening in South America right now. Unmute yourself.
Hey, Mel. Hey, my friends. So, well, Chile just beginning with this whole thing. So we are learning a lot on the experience that Spain had, Italy had, and that you are having right now. We are just beginning. I think the slope is just on its initial development, the slope of the curve, I mean, we will have some trouble, and that's what we all fear. Right now, I'm at my home because I'm COVID positive. I am a little bit,
first case.
Yeah, one of the first cases. Actually, in Chile, the first case was reported on March the 3rd. So as you can see, we're just having a month on something like that, and a days more, and a couple of days more. So people, most of the Chileans are very, very afraid of this. So we're keeping quarantine, and a lot of people have done that. And I think the measurements that the government plus everybody, people, humans, have taken of staying home has been doing a lots of good results for now. And that has given us some time to prepare.
So, Chile is probably one of the most, the richest South American countries. What does it look like in terms of how many ventilators and ICU beds do you have?
So that's a good question. We have let me tell you this info, like 400 ventilators among the country, and 1,600, we have 1,600, that's 1,600 vents for all the country, and the numbers of ICU beds are 1,400 for all the country. We have a population of 18 million people. So that's not a lot of ventilators and ICU beds for this.
Yeah, this is what we're hearing from other countries, for example, we were chatting with our colleagues in Kenya. They have 256 ventilators for a country of 60 million people. So as bad as it has been in high income countries, in middle and low income countries, this is a disaster. And the only way you can deal with this disaster is by the public health measures, because you can't deal with it when you don't have any ventilators. So you've got lots of colleagues down there, and you are going to do a Spanish version of what we've been doing starting next week, right?
Yep, that's the idea. We've gathered a lot of known ER docs from all around the continent and from Spain as well. So for next chapter in Spanish, some people from Spain are going to tell us their own experience, which is very interesting. Yeah, we're preparing this for all our folks from South and Central America, mostly. That's the idea.
So we will send that out through EMRAP. We'll let people know through EMRAP Go and EMRAP so that we can get all your colleagues on there, because a lot of this stuff that we've been doing is a lot of information transfer, but as you look in the chat, it's also about, supporting colleagues during this very difficult time where everybody is stressed. So I want to thank all of our faculty for being here tonight, all of the people chatting. We will continue to have the chat room run for a while and see if some of the faculty want to jump onto the YouTube chat and answer some of the questions directly. But thanks to everybody. We'll be doing it again next week if the desire is still there, and it seems to be that people still want us to do this. So we'll keep doing it as long as you want us to do it. So again, thanks to everybody. I thought that was a lot of very useful information. Chloroquine still isn't working, and that's a bummer. Herbert out.